you got the slides?
I have. I think I can share them.
I think when is going to show you slides?
I think I can share my slides now. Can you see?
Right,
yeah, we can see now.
So Khalid was one of our strat here, and now he's in the region. But he had performed a very nice paper survey here, about 500 patients in emergency surgery. So using the paper, I already read the title, Novel Use of Age-Adjusted Charlson Comorbidity Index, ACCI, as a risk stratification tool for development of postoperative SARS CoV-2 infection in surgical patients. Khalid, thank you for joining, and please, all yours.
Thank you very much, Prof, for inviting me. So it's quite a heavy topic. I mean, that's not topic, it's the title is quite heavy, so I'll break it down later on. So first of all, I would like to thank the team who has actually contributed very much, especially Basim, is our F2, Mr. Shafiq, Emily, Ren, and Mr. Ong and Prof. Nalo. Thank you very much for supervising this project. So the breakdown of the title, what is...
I think you have to adjust the big microphone.
Shafiq, go on mute.
Shafiq, can you go on mute, please?
Oh, I'm not on mute. Oh, sorry. I thought
because I think it makes some kind of interaction. Now, Khalid, can you start again, please?
All right. So, as a novel use of ACCI, which is Age-Adjusted Charlson Comorbidity Index, as a risk stratification tool for the development of postoperative SARS CoV-2 infection in surgical patients. So, as I mentioned, this is quite a heavy title, but I will break it down later on. So, first of all, I would like to thank everybody who has contributed in this project, especially Basim, who has contributed a lot, Shafiq, Emily, Ren, Mr. Ong, and Professor Canelo for supervising this project. So what is it actually? So ACCI is Age-Adjusted Charlson Comorbidity Index. I will explain what it is, and then novel use risk stratification tool and postoperative COVID infection. So Charlson Comorbidity Index is actually an online calculator which can be used to calculate the comorbidity index. The score is given actually by giving a weighted score of each comorbidity, so that you can have a overall score at the end once you calculate this. So it was developed as a predictor of 1 year mortality initially in 1990s, but later on there had been few modifications, and initially it utilized about 19 medical conditions, and later on 16 medical conditions, and now we can predict actually 10-year mortality based on this scoring system. And I think it's an underutilized scoring system, but it is quite valuable. So what they do is, actually we know that from the morbidities, we cannot just count the morbidities, as simple uncomplicated hypertension is not equivalent to a congestive cardiac failure. Similarly, the other comorbidities, like a simple diabetic patient, cannot be compared with a patient who has got chronic renal failure on top of diabetes mellitus or peripheral vascular disease. So it means that there should be some weightage of each condition, and it should be based on how severe the disease is. So they use quite cleverly, they have used this system for giving a total score at some point by calculating this one. So why we said this is novel use? Because we thought, because from the literature we know that COVID patients, they develop complications or even they develop infection if they have more comorbidities. So we thought, because this is a comorbidity index, can we use it to predict postoperative infection in patients who undergo surgery? And I'm more talking about the postoperative infection because it's an important thing which I mentioned later on. So hospital-acquired infection, postoperative infection means that hospital-acquired infection after the 7 days of surgery. So we have not included any patient who had the infection at the time of surgery or before the surgery. So the risk stratification tool means that we wanted to know whether the low score is associated with low infection and the vice versa. So this was the aim. So importance of this study is that we know for the last 1 year, since October 2019 or November 2019, we are at the disposal of coronavirus for the last 1 year. and it has affected almost every part of the world, and it has affected our every aspect of life as well. So you can see that the economy is badly damaged by this one, and as are the health related all the disciplines, especially surgery. So to begin with, the issue was that we cancelled all the elective surgeries because we thought we can reallocate the resources. We wanted more beds in ICU and HDU. We didn't want to operate on these patients so that we have more resources to allocate to the COVID positive patients. But later on we came to know actually it's more complicated than that. And the complications are that the patients are at risk of developing infection from the other patients or from the surgeons, and the surgeons are at risk of developing infection from the patients. So it's not a simple equation. So and we are just getting another peak. The second peak is about to strike us now, and on daily basis we are getting more than 20,000 patients. So which means that the lists which were cancelled previously during the first peak, they cannot be actually managed. We cannot operate on those patients, and we are getting more patients again. So 2 months ago there was an estimate that if there was about 0.5 million patients in UK only who were not operated, and 36,000 of them were cancer patients. At that time they thought if we do 20% extra activity, which involving the of course the private sector, and then putting a lot of funds, about 2 billion, then it will take more than a year to sort out these lists which have been cancelled. So it means that essentially getting afraid of the COVID virus and then just sitting tight and not operating on these patients is not the solution, because the waiting list will get on complicated and more complicated. Now they have done a bit of work on that, and one is that clinical validation of surgical waiting lists. So they have created one a system that we should prioritize the patients, and they have been these priorities P1 to P4, they were already existing, but P5 and P6 priorities, these are an attempt to reduce the number of patients on the waiting list. And what they want to do is they call every patient and call them and ask them, are you concerned about COVID-19 infection, and do you want the surgery to be postponed? And the second group of patient is that their surgery must be postponed because of non-COVID reasons, which could be social reasons or any other reason. But it looks like a nice attempt that they can reduce. But how many people will actually be categorized like P5 and P6 just to reduce the number of patients? Probably it's not going to work. And just giving an examples what P1 and P2 is. So P1 is laparotomy, which requires surgery within less than 24 hours. We cannot refuse surgery in these patients. Doesn't matter they are COVID positive or there is a risk of positivity or negative, or they are negative, because these patients require emergency surgery. Here the status is not the COVID which determines patient should go under surgery. Rather it will be P-possum scoring system or something other, the risk of morbidity and mortality, which will determine whether this patient should be operated or not. And there is another procedure like small bowel resection not responding to conservative management. So there is no point that, but the point I'm trying to make is that the P1 category, they will never be cancelled or they will never be refused from surgery based on just the COVID status. The major issue is in the P2 and P3 categories. So these are the patients like they require a cholecystectomy as an elective, or they require inguinal hernias. So if we utilize that system, then how we will manage this patient who requires a cholecystectomy, and the patient is, compare a patient who is very young and fit versus a patient who has a lot of comorbidities. So here comes the role that what would be the risk of infection and its complication in an elective patient as compared to a patient who has a lot of comorbidities. So the decision here would come that the patient who has a greater risk of developing postoperative infection, they should actually be avoided from the surgery. And this is what we are suggesting. We suggest that get a diagnosis first of all, and in every patient calculate the ACCI score, and if the score is 0, then offer them a surgery. Doesn't matter it's an elective or emergency surgery, because this is a low risk group. These are the quite young and fitter patients, and you can get away with this surgery without having complications, primarily because they will not develop infection, and secondarily if they develop infection they are not at an increased risk of mortality and morbidity. And the high risk patients, which is a score of 4 or more, They are actually the patients who have got very high risk of developing infection first of all, and then getting complications out of it. So such patients, first of all, do not offer them P2 to P4 categories. So discuss with them that these patients are that you are at a greater risk. However, if they have a P1 category, they require emergency surgery, then we have to do some extra precautions, like these patients will require an isolated room so that they do not get infection from the other patients. And secondarily, we should offer reverse isolation in these patients. The intermediate group is the one which actually can be between the two, which I mean is that in those cases, offer surgery P1 and P category, do not offer surgery if it's an elective, and optimize these patients, because the scores sometimes they can move across the classes. They can go to category 1 or can go to category, the score can go into low group or the higher group. So if we optimize the medical condition in these patients, they will score low. Once they score low, they can be operated for elective surgery. From where we got this concept and what is the evidence behind that? So we have done a prospective observation study. We got data for 8 weeks starting from 1st of March. And the sampling was actually every individual who got operated. So convenience sampling and purposive that every patient who has got an infection, who got a surgery done, that was included in the study. And the follow-up period was 30 days. We actually had a follow-up period of 90 days, but we included in this data 30 days. And the outcomes included postoperative infection, morbidity, and mortality. So we use a multivariate analysis, univariate and multivariate both analysis, and we had 518 patients who underwent 550 surgical procedures over a period of 2 months. Now, the COVID test was selective at that time. We were not operating on everybody. We were not doing COVID test on everybody in those days. The patient who had some suspicion of infection because of the chest symptoms or any other reason, then we were doing the COVID test. So 32%, which was actually at that time a standard across the country. So 32% of the people, they got tested and 52 were positive. And 131 cases were confirmed negative. So among the 52, there were 15 patients who had infection at the time of surgery or before surgery. So we excluded those cases. We included only the patient who had infection between 7 and 30 days. So we found that the median time duration to develop infection is around 11 days. So if a patient remains 11 days admitted in the hospital, then they are at risk of developing infection. Now, this is, of course, during the situation where you have a standard precautions in place. So we had all the pathways, green and red pathways in place at that time. So if all the post-operative patients are exposed to equal chances of getting infection, then only about 12% of them will develop infection around the day during the 11-day hospital stay. So these patients would develop for equal as male and females. The mean age, look at the mean age, is about 77. So it's really matching with the worldwide data that the average age for developing infection is above 70. So 23 postoperative complications developed during these 17 patients, and most of them, they were respiratory complications as expected. The other included postoperative infection, wound infection, thrombotic complication, UTIs, and need for intensive care therapy. The in-hospital mortality was 16%, which was slightly lower than the mentioned in the literature, because literature mentions 18% and 23% from COVID surge group. Now, we wanted to know that why everybody has not developed infection and why few people develop infection. So if we do the analysis, this is a univariate analysis, and we can see that the factors which predict developing infection is the age, first of all. Being in the age group beyond 60, beyond 70, that puts you at a higher risk of developing infection. So these are the people who have a higher risk of infection beyond 70. And then there was no difference between age, between gender. ACCI score, if your score is less than around 2, you are not at risk of developing infection as compared to score of 6. And if we go the score 0, 1, 3, and we grouped it actually, score 0 was group 1, 1 to 3 was group 2, and more than 4 or 4 was group 3. So here you see the incidence, which I'll explain in the next slide as well. The incidence increases if you are at if you have a higher score, you had increased risk of developing infection. The other factors, which was like pathology or specialty, especially if you have undergone a trauma in orthopedic or vascular surgery, you are at increased risk of developing infection. If you have undergone certain type of anesthesia and the surgery severity score. So these all are the factors which actually determine the development as a factor for developing infection. But these may have some interplay. They may be actually one is playing with the other. So we did a multivariate analysis. And from that analysis, we put all the factors which actually were contributing. So we found that the ACCI group, that actually has in a multivariate analysis, that is the factor which determines postoperative infection, along with undergoing an orthopedic or vascular procedure. We haven't explored this much because there are multiple factors again playing with one another. So we have, we assess this ACCI as a stratification tool for the development of infection by doing other analysis, and that is sensitivity and specificity analysis, or the diagnostic values. So what we know is that if the score is 0, then the risk of developing infection is 1.3%. Only 37% of the population from a group 0, low risk group, they develop infection. But if the score was between 1 and 3, there was 13% incidence, and group 4 or more had 1/3 of them, they develop infection. We didn't have any, the maximum score for ACCI is 12. We didn't have any patient belonging to this group. Now, we did the same thing as Salman has done, that we did the area under the score, area under the curve, and ours, area under the curve shows that there is 0.797. It's almost 0.8 area under the curve, which means that this is quite a diagnostic, and it actually can rule out the chances of getting infection in patient if it belongs to category 1. And it has a very high sensitivity. And if we compare this with the other, like the area under the curve, comparing it with just an operative severity score or just age, so this was more predictive as compared to the other, which is 0.67 and 0.58 in case of the operative severity scoring system. And this is quite evident from the graph as well. So what we suggest is that, first of all, define the surgical diagnosis, calculate the ACCI score. If the score is 0, offer the surgery, whether it's elective or emergency. If its score is between 1 and 3, then surgery should go ahead, while the other surgeries, patient should be optimized. The score 4, they offer surgery if the other factors like the p-possum allows and the other the parameters allow. And these patients should be kept in isolation, and also provide them reverse isolation, means only a few people should be visiting them and not the whole team. So what would be the implication? Implication would be that we can actually get the waiting list down very quickly if we utilize this policy, and there will be not an overburden on the system in the future years. Thank you very much.
Thank you, Kari. Question from the judges. Kathy, please.
Yeah, thank you for that. That was very interesting. I think also just thinking about one of the previous presentations, I'm just wondering if one of the other potential steps might be in actually reducing planned stay in any way you can. So one of the earlier presentations we were hearing about was same-day discharge from mastectomy. So I'm guessing if the length of stay is going to potentially also affect whether or not people develop COVID, whether looking at the length of planned stay for any procedure might be another thing to look at.
Are you there?
Yeah, so yeah, I totally agree with that, because our data suggests that the duration of stay, longer duration of stay, means that you are at a greater risk of developing infection. So planned surgery should be, should be planned in a way that the patient get home as quick as possible.
Okay, thank you.
Thank you. Tim, please.
I'm just wondering whether length of stay is not a big compounder here. Because I think although you've nicely demonstrated that this risk score applies to COVID infection, surely as it's a risk of comorbidities, that's going to increase likely length of hospital stay and therefore potential exposure to COVID. Do you know, did that factor at all in your multivariate analysis, the length of stay?
So we measured length of stay as an outcome rather than as a predictor of developing infection. So there was a variation between, I will put it another way. So the longer stay in the hospital was a predictor of developing infection. So there will be other factors which have put the patient in for a longer stay in the hospital. That would be getting a surgery which was quite a severity where they required a longer stay, or developing other complications other than the COVID infection which kept the patient longer in the hospital. But definitely staying in the hospital for longer duration, because you get more exposed to the other patient, you get more exposed to the team members who are taking care of you, so you are at a greater risk of developing infection if you stay longer in the hospital.
Okay.
Thank you.
Thank you. Any questions? Okay, thank you. Khalid, can we go straight to your next presentation then?
Yes, please.